Hello, good morning. I am Dr. Ranganathan. Today, the topic given to me is early extubation tricks and approaches and fast tracking in pediatric cardiac surgery. So, I, at the onset, like to thank the organizers for giving me an opportunity to talk on such an important topic. So, I have no financial disclosures. So, in the next 20-25 minutes, I would like to talk to you and walk you through the evolution of fast tracking as a concept and how to choose the right patients, contraindications and common concerns, practical strategies across surgery, anesthesia, and postoperative care, and finally, some key take-home messages for fast tracking. The purpose here is not to give a shortcut actually, but to give you a framework of thought as to how to make fast tracking safe and consistent in every unit. So the concept of fast tracking started from the 1980s when Barash et al. Published his study on fast tracking of cardiac patients. So in that study, he found that demographic of patients definitely had a role to play in terms of achieving a high success rate for fast tracking of patients. The higher the risk for patients and the bad subsets that he had to do, they eventually ended up having a longer ICU stay or hospital stay, as the case may be. So many centers practically were ventilating most of the pediatric cases till the mid 1990s with a long-term ventilation. So the, this was partly because of the practice of using high-dose opioid anesthesia and prolonged bypass times, longer-acting sedatives and anesthetics that were used, and concerns about pulmonary and cardiac dysfunction arising out of all that. So we had this 6 hour to 12-hour rule where most of the kids were ventilated, thinking that the pulmonary and cardiac dysfunction will kick in, and most of them will do well with post-op ventilation. Today, the paradigm has changed a lot, and we manage CPB better, anesthetics better, and we have better post-op nursing care and good monitorings. So the fundamental question has changed from should we extubate to how and when and on what framework we can extubate kids on a fast track basis. So, how do we define fast tracking? Fast tracking is not just early extubation, it's a comprehensive perioperative pathway that includes same day admission, preoperative education of the patients and the staff involved, careful airway and coagulation management, judicious use of opioids and sedatives, and aggressive pulmonary care and physiotherapy. So, early mobilization and feeding are an important integral part of defining what fast tracking is all about. Early removal of chest tubes and pacing wires, and finally, structured variance tracking and auditing. I can't stress on the importance of various tracking and auditing because we need to know at what point do we get stuck. Do we get stuck at the ICU level or at the level in the wards for discharge? So we need to know what hurts us and what prevents us from progressing. So auditing and variance tracking is an important part of bettering your fast tracking programs. So when we say fast tracking, we are not just talking about, we are just talking about systems and not just a process called extubation. So how do we choose patients? Selecting the right patients is very important for um, uh, fast tracking. So we use the RAC scoring or the STS scoring or the Aristotle scoring for pediatric patients that gives the surgical complexity. Age and weight do play a prominent role in fast tracking of pediatric patients. So it's a no-brainer why it does that. So along with those, we do have issues with the pre-op status, whether the patient was intubated, ventilated, was he on Prostin, or was the patient on inotropes preoperatively, and was there any intraoperative complications that involved while doing the procedure. So all this do play a part in choosing the right patients for fast tracking. So when you see this slide, it shows the extubation failure in neonates after cardiac surgery. This is not necessarily fast track patients, but neonates in general. So if you can see that about 16% of neonates had failure of extubation, post extubation, even for normal extubation, leave alone fast tracking. So there is a high rate of extubation failure in neonates. So this needs to be kept in mind while dealing with fast tracking of smaller kids. So the reason and the concerns, particularly in neonates, arises from the immaturity of the respiratory system, the smaller airways prone to edema, high sensitivity to anesthetics and anesthetic agents because of poor neurological development, and the immature hepatic and renal clearances of drugs do play its part. So the intubation rates for congenital cardiac surgery post are very high in neonates and less than 3 months, like 21% to 7% in the general population. So you can see the frequency distribution of age group that is extubated within 24 hours. And it shows neonate at 63%. So 63% neonates got extubated as against 99% of patients post 12 months of age in a particular study. So that shows the vulnerability of the neonatal age group for fast tracking. And what are the reasons for uh, uh, failure of extubation? Mostly it's related to atelectasis, poor gas exchange due to pulmonary dysfunction, low cardiac output and hemodynamic instability, and upper airway obstruction and pulmonary condition. These are the 5 major reasons why patients got reintubated post fast tracking or even otherwise. So what are the strategies for fast tracking? We have two, namely the surgical and CPB related, ICU and anesthesia related. So let's go one by one. Strategies for surgery and CPB. So key surgical precision is the first pillar for fast tracking. As I always keep saying, fast tracking is as much about surgery as it is about anesthesia and IC care. So key components include smaller surgical incisions, quicker surgeries, good hemostasis, very good myocardial protection, because most often if you have a good myocardial protection, that prevents patients from going into low cardiac output because of various myocardial reasons, and care during retraction, warm heart surgeries, ultrafiltration, and use of newer blood units, especially for the smaller ones like the neonates. So each of these directly impact postoperative function and the feasibility of early extubation. The anesthetic and ICU strategies include short-acting relaxants, paralytics, and analgesics, correct and appropriate weight dosings, appropriate ET size for avoiding airway edemas, full range of monitoring, which helps in getting the confidence of monitoring all the major systems. And we know for sure that things are okay, especially the cerebral and renal oximetry. It does help a lot. TE is an important pillar for fast tracking because it gives the confidence to know that we have no residual surgical issues, and if at all there is a surgical issue, what it is and the extent of the surgical issues that is left behind. Full rewarming, optimization of electrolytes, diuretics, all are very important part of anesthesia and ICU strategy. Use of postoperative nerve blocks has been practiced, but I feel the use of IV analgesics is equally good. Anticipating PAH, pulmonary artery hypertension, and pre-treatment with IV sildenafil is a very important part of patients who are prone for PAH postoperatively. Elective non-invasive ventilation is an important strategy as well, because as you have seen previously, atelectasis and lung dysfunction are major reasons for reintubation post-extubation. So elective NIV definitely plays a part. And the other one is anticipation of low cardiac output and preventing it by keeping by avoiding early weaning of inotropes if required to keep them as it is till such time as you know for sure there is no more threat of low cardiac output. Frequent blood gas blood gas studies help us to know the trend of PO2, PCO2s, and electrolytes so that appropriate corrections can be instituted. Use of bedside echo as and when required cannot be stressed more in case of fast tracking. Lung ultrasound again helps us in knowing collection of blood or fluids or pulmonary congestion or collapse. So it plays this role in fast tracking. So as you can see, these are the nerve blocks that's been instituted. But as I said, IV analgesics and early removal of chest tubes or infiltration locally at the time of incision or nerve blocks by the surgeons themselves in case of thoracotomy are equally good strategies to employ. So what are the usual concerns to fast tracking of patients? So there are various concerns that prevent us from fast tracking of different patients, right from age-related issues, anatomy and physiology of the patients, syndromic kids, long pump and clamp times, deep hypothermic circulatory arrest and low temperature surgeries, airway-related issues, nerve palsies, chylothorax and chest tube collections, residual lesions, poor functions, bleeding issues as in cyanotics and factor deficiency, anticoagulation management, example as in Fontan. So we need to optimize coagulation management. So he may stay in the hospital for long, even if it's getting extubated early. Superficial skin infection and wound infection do play a part in neonates and the cyanotics. So, and look out for sepsis. So, early delining, cultures, and close monitoring are required to prevent sepsis post cardiac surgery. So, these concerns should not discourage fast tracking, but they must be anticipated and looked for and treated at the earliest. So if you look at the lesion-wise categories, you can see the single ventricle physiology, the TETs, the kind of surgeries that has high risk, like a palliative surgery, like a BT shunt in a smaller age group, PA banding, all these carries very high risk for extubation failures, uh, even in a normal case scenario as against a fast track patient. So we have to be anticipating this kind of issues for those kind of kids and be ready with the solutions as to how to address it and how to go about it. So coming to syndromes, the usual syndromes that we come across cardiac surgeries, Down syndromes, and usually they have airway related issues. So better to be ready to deal with airway issues as and when it requires in a Down syndrome kids. 22q deletion, the possibility of infection and dynamic airway collapse, again, the need for NIV. Then you have this Williams syndrome kids who have a very stiff, poorly compliant lungs, and the incidence of low cardiac output is very high for them, and there's a high degree of difficulty to sedate such kids. So the triad of failure for syndromic kids is the genetic syndrome associated with long CPB and RV dysfunction. So these kind of kids, it's better to avoid early extubation. Coming to CPB related issues, systemic inflammatory response and activation of inflammatory response by the CPB circuits and immune suppression are uh, uh, are some of the more important CPB related issues that we deal with, which can prevent fast tracking of patients. And capillary leak is especially important in neonates. Neonatal tissues, kids are more prone for capillary leak and they may third space, and that may prevent them from breathing well and attaining a good PO2 and prevent them from having good gas exchange. So you should be on the lookout for capillary leak and do whatever is required to prevent that. And myocardial ischemia and reperfusion injury is more common in cyanotic kids. So be on the lookout for that. And immature myocardium and the inability of the pediatric heart to handle calcium can result in diastolic dysfunction and low cardiac output. Neurological injuries like watershed infarcts due to non-pulsatile flow, coagulopathy and bleeding, pulmonary dysfunction, and high risk of AKI or acute kidney injury all add to the mortality and morbidity post CPB. So each 10-minute increase in CPB increases a 2% composite morbidity increase. So that's how we have this CPB related issues. So solutions include the judicious use of steroids, ultrafiltration, zero balance filtration included, and goal-directed perfusion strategies. Airway related issues. History-wise, look out for stridor, and during your examination of the child, you have to look out for micrognathia, the possibility of laryngotracheal bronchomalacia, absent pulmonary valve syndrome cases, and even big BST, which can obstruct the left bronchus. So be on the lookout for such airway-related issues for specific cases. Vascular rings, subglottic stenosis and edema, large tongue obstructing and during sleep. Vocal cord palsy and phrenic nerve palsy are two more common problems that can cause airway issues. Nerve palsies, as I said, phrenic nerve occurs about 3% in arch issues, arch cases, PDAs, BT shunts, and Glenn and Fontaines. Recurrent laryngeal nerve injury is a very under-recognized issue that can hurt your fast tracking. So it occurs about 5 to 10% of cases. It presents with weak cough, aspiration, stridor, and feed intolerance. It usually recovers by 6 to 12 months of age, and it's better to institute thicker feeds to avoid aspiration. The nerve palsies may be due to eye/cautery or dissection, and diagnosis can be done by X-ray, USG, and fluoroscopy. The idea is to look out for nerve palsies when there is a failure of extubation. So again, coming to chylothorax, this is another important reason by which patient stays long term in the ICU or in the ward, especially post Fontaine, Glenn, Norwood, and tetralogy and coarctation. So the risk factors of chylothorax includes redo, SVC thrombosis, and Down and Noonan syndrome kids definitely have a high risk of chylothorax. So to be on the lookout for chylothorax and instituting appropriate management techniques to deal with that forms strategy for fast tracking of patients. And residual lesion is one of the most important things that can hurt you in the long run. So there are various criteria that's been applied to so that you don't fast track such kids if there are some residual lesions like a QPQS of more than 2.1, a gradient of 30 millimeters of mercury on echo, and RVOT obstruction with RVSP of less than 50%, pulmonary venous congestion with pulmonary venous gradient of less than 5, and common the regurg gradient of more than 25% of atrioventricular valve, and arch obstruction with 20 or more of gradient. And if there are coronary lesions, especially if you have done an ASO and L-kappa, there may be a possibility of low cardiac output due to LV dysfunction and the possibility of arrhythmias. So these are lesions when you have, you should ideally postpone fast tracking. So coming on to poor function, poor cardiac function per se, according to me, is not a contraindication for fast tracking, but definitely there are various things that you can do to avoid getting the child reintubated, like keeping a good dose of afterload reduction and continuing inotropes in the immediate post-extubation period, putting on CPAP, good use of diuretics, and echo assessment frequently to know where we are, and the most important thing, eternal vigilance, so that we can re-intubate the kid if required. Bleeding issues is another important post-op complications that can that can prevent good fast tracking program. So most important thing, everybody gives blood and blood products, but the idea of keeping a good crit is sometimes missed altogether. We are so enthusiastic in giving blood and blood products, but we fail to keep the crit above 30. So a good crit is more important for preventing bleeding. So that's one important thing. Anticoagulation management, as I said, for kids with Fontan, conduit, and all these cases, which may be requiring oral anticoagulation postoperatively. So they need to have a good oral anticoagulation strategy panned out. So they may stay longer because in the third world setup that we have in India, we may need to take a watch on how to institute and optimize oral anticoagulation management. So we need to optimize them before we can fast track them and send them away from the hospital. So coming on, so what are the take home messages? So the most important thing is there are no tricks or shortcuts available. We have to stop equating, as I said, early extubation with fast tracking. Fast tracking is a process and it's a system, and early extubation is just one part of that process. We need to separate the hours of ventilation, the hours of ICU stay, and the length of hospital stay. And each need to be assessed separately for all cases and audited so that we have refinement of techniques and protocols in place to know and to help us to deal with the problems that is unique to our setup. Definitive benefit of early extubation for specific cases like Fontan, Tets, and Glenn are there, and so these needs to be followed, and these cases needs to be given the benefit of early extubation always. Eternal vigilance for monitoring variance occurrence is an important part for improving patient outcomes while instituting fast tracking protocols. A strong ICU nursing and physician care and continuing education programs so that we are all up to date about how to take care of our fast track patients. Early pickup of impending problems can happen when we have a strong nursing and physician program. And the last but not the least, not to shy away from ventilation and don't be under pressure to extubate everyone. If required, ventilation is a good strategy and you should employ it. So, with this words, I wind up my lecture today, my talk today, and thank you for your patience and thank you again. Thank you.